Welcome to this TNT. TNT stands for Tools and Techniques, and it is a sponsored session. It means that we have to say thank you inside LifeTech for having made this possible and arrange all this. And look at the interest that you have in the room. I think it was worth the effort to organize this physiology session, because what we are going to do is to refining percutaneous coronary intervention and discussing a lot about physiology and intracoronary imaging with a panel of true experts in the field. So let me start by my spokesperson and co-chair and friend, Salvatore Brugaletta from Spain, next to me. Then on my left, Carlos Collet from Aalst in Belgium, Dr. Chun Chang. Tell, where are you from? Because I cannot pronounce your city.
From Hangzhou, China.
Voila, that's easy, China. Sorry for this. Jacek Legutko, this I can say, from Poland. And Felix Wojtek, tell where are you from? Just for,
Dresden, Germany.
Okay, that was also a difficult one to pronounce. Thank you very much. My name is Emanuele Barbato from Rome in Italy. I think we can go through the session objective. I don't think there is a clicker. I need to go there. So our objectives today are the following. To understand the role of physiology and intracoronary imaging in PCI decision-making, we would like to explore together with you the use of the pressure microcatheter in PCI procedural guidance and optimization, and to learn the benefits and application of a novel IVUS HD-IVUS, high-definition IVUS, that is now available. This is the content of the session. One live in the box, one recorded case from the Cardiovascular Center of the second affiliated hospital of Zhejiang University School of Medicine in China. We have two focused lectures, one on trend and future of coronary physiology, one on trend and future of intravascular imaging. The team, I already introduced you with the team, but I think it's important, Salvatore, to remember that this session is an interactive one, so we don't want them only to eat and drink, but also...
Yes, exactly. So we would like, you ask as much as you want, so because we don't want, that you leave the room so without everything. So we have a microphone here in the middle of the room, but you may use also the app, so to make any questions that I have here in front of me, so all the questions that you may ask, we will pick it up.
I thought I could have been there. I cannot because I have to push on the click.
Welcome you to Cardiovascular Center in Hangzhou, China. My name is Jacek Legutko. I'm from Kraków, Poland, and I have the privilege and real pleasure to be here and to do cases with Professor Jin Jiang, really experienced operator. And please introduce your team.
So I'm Dr. Jun Jiang from Second Affiliate Hospital, Zhejiang University School of Medicine. Today we have Dr. Xu Cao from Hunan. He's also one of a fellow received training in our center. So today we have a very interesting case. Briefly, this gentleman, he had an acute inferior myocardial infarction 1 month ago and successfully treated with primary PCI in a local county hospital. So today we can see the RC stent is patent, and also the electrocardiogram itself only a small Q wave in lead 3. So it's actually the vessel is opened very early, so the myocardium, most of the myocardium are preserved. So today our target is long diffuse lesion in left anterior descending artery. You can see the two diagonals we need to protect, and very long diffuse lesion of this important vessel. So usually what will be your strategy for this kind of lesion in a young patient?
We discussed this extensively, how to treat this patient, and our decision was first to do it with physiology and intravascular guidance to achieve as good as possible result according to ischemia, but also to optimize our stenting procedure. So maybe we can go immediately for wiring of these vessels, and then we will start with physiology.
Okay, that is what the colleagues in the cath lab had as a strategy, but let's go stepwise. Let's start reflecting together how we would treat this patient in our cath lab. This is a young patient, 44 years old, acute coronary syndromes, multivessel disease. They treated the culprit lesion, the right coronary artery. We are left with a long lesion or even sequential stenosis in the left anterior descending coronary artery. We are not here to discuss options between CABG and PCI. We are at EuroPCR, so we need to deal and cope with this patient in the cath lab. In addition, I tell you, my opinion is too young to be sent to the surgeon, so let's get rid of this option. And let's discuss about possible alternatives here. We heard about physiology, imaging guidance, a quick round of opinion in the panel. Very short answer. Would you go for physiology guided, imaging guided, or angio guided? Let's start with Carlos.
Certainly physiology to understand how severe is the disease and what is the distribution of disease, and imaging to guide in the PCR.
To Jacek, you did it physiology guided, we know, but do you think this can be simply done with angio guidance, and if not, why?
I believe with angio guidance, we will always finish with the stenting all along the vessel, so it's the worst scenario for me. The problem is if we need to choose between physiology and imaging, because they are both expensive and in some countries there are limitations to do so. So probably at this stage of knowledge and my experience, I would prefer IVUS guided procedure to get optimal stenting result.
So if you really had to choose between one or the other?
One or the other, but
okay.
I have more and more experience with using also physiology to optimize stenting, and there are some additive values of both. And
Sure.
I believe that what we have done in China would be very interesting for all of us.
To Felix, at the end of the table there, what's your guess? Anything different from what you heard so far you would do?
So it's a long lesion, it's a 44-year-old. So first for discrimination of if you want to treat it or you have to treat it, physiology, if you have to treat it, use the IVUS to optimize it. You want a long-lasting result, you may get away with less stenting if you do imaging, so just treat the culprit if you have to, but this has to be demanded or directed by physiology.
In the room, who would go with physiology guidance here? Raise hands. Okay. Who would go for intravascular imaging guidance? Raise hands. We are split. Who would go for both physiology and imaging guidance?
It's not.
Okay. Who would go with nothing guidance, angio guidance? Raise hand. You don't dare to raise hands, huh? That's why. Okay, let's start from physiology guidance. When we say physiology, we used to do only FFR a few years back, but now there is a world out there of physiology. Which kind of physiology? Let me hear again, Carlos. Resting, hyperemic, with pressure wire, with microcatheter, with angio. How would you do physiology here?
So I think all the options are open here. I think it's nothing wrong to do only resting or only hyperemic. I think both will be more or less the same results. Now, the provocative comment that I'm going to make to you, Emanuele, is you have the microcatheter that basically makes doing pullbacks extremely easy. So I would say, why not doing both? Sometimes if you have some doubts in the interpretation of the information.
If we need physiology only to decide on revascularization, and especially for patients scheduled for surgery, for me there is no difference between those tools. But in patients, especially with such complex disease, I believe that what we have now with microcatheters is very convenient, because you can use it very easily with the regular wires during all the stages of the procedure, not necessarily, and you don't need to exchange the wires multiple times. So I believe that it changed our landscape.
Dr. Chang?
So personally, I will prefer hyperemic, either with wire or with a microcatheter-based device.
And finally, Felix.
Yeah, I mean, I would probably do both, like hyperemic and non-hyperemic, and see. I mean, we want to be very sure that we have to treat this LAD because we're going to place a stent in a young patient, and it might fail over time. So I would probably do both, and if I have this together, I can decide if I really have to treat that. And then, of course, I can go in with my normal workhorse wire, and we know how we love to use our one workhorse wire. We are never changing or not much. And with a catheter, that's possible.
Why don't we address the first unmet need here, Carlos, about latest trend in coronary physiology? Why don't you give us an overview of what are the available options?
Thank you again, Emanuele. And I think that physiology, and perhaps everybody in the room already knows this, but this is an evolving field. And the way that we were doing physiology 5-10 years ago is completely different from the way they were approaching physiology today. And the big question to understand this is, it's a good question to understand why to do physiology, or what does physiology offer. And I think in this slide, we kind of summarize everything that physiology has to offer. First, you can increase the accuracy, understanding how severe the disease is. Second, I think we have demonstrated this systematically, how physiology helped reducing complexity of the intervention. And the ones on the right side of the slide, this is where we are today. And this is completely new. It's basically using physiology to predict what's going to happen after PCI. And we didn't know that physiology could do this. This is, again, a new field. And what you're going to see on the far right of the slide is basically what we're testing today. That's going to be the future, and I will explain very quickly. So basically, when we think about addressing the accuracy or increasing the accuracy and understanding whether this disease is significant or not, honestly speaking, look at the slide. It's very complicated to say that this lesion requires treatment or not. You need physiology in these cases, and this is the classical indication. This is intermediate lesion. I would not go into this. I just want to mention. And the second part is basically reducing complexity, which we have seen in the syntax trial. When you look at this is the data from FAME2, looking at the division of the syntax TER cells in the data, and you see here 34, 34, 34. But when you apply physiology, look what happens. You basically reclassify patients to a lower disease complexity, and that makes your life, of course, easier. And that results, of course, is you reclassify the patients that will be better treated with a different therapy. You, in this case, if the LAD is negative, it's not anymore a surgical case, so you'll be treating percutaneously the right and the circumflex. And again, you reduce the number of stents that we know on long term is beneficial for the patients. Now, what is new? Well, basically, with physiology, we can predict the efficacy of the treatment that we can offer. And I will explain you why, how. Basically, in the past, we are all familiar with this number, 0.8 for FFR. This is what we call the single distal point. But the second half of the information that comes from physiology is basically on the pullback curve, and I will explain why. So we're going to use this model. This is an animation meant to understand what happens in the coronary when we do PCI in focal and diffuse disease. And we're going to start with the simple part of the story, which is PCI in focal disease. I'm going to play the animation. And basically here we're going to put a sensor of pressure in this coronary, and we're going to do a pullback. Just, put the sensor distal, start pulling back. This takes about 20, 30 seconds. The FFR distal will be 0.7, but look what happens. When the sensor of pressure crosses the lesion, you see this big step in the curve. If you see that step, you're going to help the patient. How? Well, we all know how to do PCI. Basically, we treat the lesion, we remove the resistance at the level of the epicardial vessel, and this is what happens. And if you measure post-PCI fractional flow reserve, it's going to be high. Now, let me show you the other side of the coin. This is a case with diffuse coronary artery disease, where we're going to do the same exercise. So we're going to measure the pressure longitudinally along this vessel, and look what happens. If you measure distally, it's going to be 0.7, the same as focal. So you don't know what you're doing until you do the pullback. When you start doing the pullback, you don't see this big pressure jump. But if you're using angiography only, you might say, here looks a bit more tight. Usually we put longer stents. Look what happened to the curve. If you measure fractional flow reserve, it's going to be low. Basically, you just treated diffuse coronary artery disease. Why this is important? After the PCI, if you ask the patient how they feel and you have treated diffuse disease, you will see that more than half of those patients remain symptomatic after a successful PCI from the angiographic point of view. And if the patient had a focal endotype of coronary artery disease, those will be symptoms-free. Now, how to assess this? Of course, there is the classical way using the pressure wire. The pressure wire is a familiar device. Many of us have experience with the pressure wire, has a smaller profile, and sometimes it can provide additional indexes. But then we have this new technology called pressure microcatheter, which basically facilitates the performance of the pullback in the sense that you don't lose the position of your wire. You keep your work of wire as Felix said. I also like to work my work of wire, put it distally, and just put the microcatheter all over, and you can repeat that measurement as many times as you want. Okay, so that's basically the advantage, and I believe this is a new generation of pressure microcatheters because of these have evolved over time. The profile of this device now is smaller from the ones that were previously in the market, and as their other devices, they also have a proprietary non-hyperemic index that is a diastolic index called CRR, so you can of course measure resting, and you will see in the live case how they measure CRR. Now, what is the frontier? What were we doing today, and many of the colleagues on the panel are involved in this, is how to use physiology to optimize the durability of the treatment. And basically, we're talking about, we have already implanted the stent, so we're in the post-PCI phase. So what physiology has to offer in that particular scenario, in that particular phase of the procedure? Well, there are three things that can happen. One, of course, if you treat a diffuse disease and you measure physiology again, you're going to have low flow, low FFR, but you have nothing to fix. You basically have to live with the fact that you have treated diffuse disease, and that's an important information. But there are two scenarios when you can do additional maneuvers that we believe are going to be associated with improved outcomes. The first one is the fact that after treating one lesion, you can unmask what is the contribution of the distal lesion and understand whether additional stent is needed or not. And the second part is something that we're using as well, and Jessica has shown beautiful cases about this, is that sometimes when you have severe stent under expansion, you can look at the translesional stent gradient with physiology and just optimize stent implantation on physiological grounds. And that's quite exciting. So we're performing, this is one of the largest clinical trials in the space of physiology. It's called Insightful FFR. Professor Barbato is the leading PI of this study, and we're basically randomizing the patients to two groups. One group which is going to be guided by the pressure microcatheter, and the second group is being treated with the standard commercial pressure wires. And if they go to PCI, we're going to randomize them again into using physiology to optimize the stent implantation, so try to achieve the higher FFR of higher amount of flow after PCI versus a standard of care. We basically mean don't check anything, finish PCI, if it looks good, you're out. And this is a clinical study. The primary endpoint is MACE, and we're pretty advanced. We have already 700 patients including the trial, and we believe we're going to finish recruitment next year. In summary, I think coronary physiology has evolved from a method that was a diagnostic method to a tool that is actually guiding the procedures, both in the pre-PCI and the post-PCI phase. I think that the pullback maneuver is an essential part of performing coronary physiology, and I think this device facilitates that, and we believe that physiology-guided PCI, if this trial is positive, is going to become part of the standard of care. Thank you very much for your attention.
Can you do something for me? Can you click on the next slide?
Of course.
One more? Thank you.
Okay, so actually our fellow already wired this vessel with a samurai, and now we are started the FFR.
We will use in this case through physio microcatheter. This specially designed to measure intracoronary pressures, and this is the special feature of this device is that you can use it with every guide wire, 0.014 guide wire that you want to use for PCI, and you don't need to remove this wire. It will stay all along the procedure and can repeat many times and multiple steps of the procedure physiology measurements. It is really low profile design. Now zero PDPA was done, and the catheter is ready to be introduced. It is a long monorail system.
Yes, very tiny catheter.
Yeah. And very good profile. 0.020 is really low profile device. So there are two markers on the catheter. They have to be out of the guide. The proximal one is just the pressure transducer, so we need to equalize. The sequences of the procedure are very similar to what we do with pressure wires. The most important difference is that we use regular wires, and we don't need to withdraw wire after the measurement. So we are going across the stenosis to the distal part of LAD.
I think so just enough.
We can maybe start first with CRR, and you can easily see that we have significant gradient there. The value is 0.68, so There is definitely ischemia, which is maybe not so strange, but what we are interested in is to do the pullback, and we can do it now even with non-hyperemic gradient, because definitely we need to intervene. So we are slowly, Professor Jan is slowly pulling back this microcatheter across the stenosis. The value is still similar. So there is the most significant step ups are in the proximal part, of this vessel. So it's interesting. You see, they do have very diffuse disease. However, with this first measurement, the most important pressure gradient is across the lesion, which is in a proximal LAD from first diagonal just to the proximal LAD.
Maybe we do FFR.
Yeah, we do FFR now, and we can then repeat a pullback with during the infusion of adenosine. Has the infusion already started?
Yes. 药已经开始给了啊，可能会有点闷啊，现在开始用药了啊。
Is it 140? Oh, 140 micro?
Yes.
Okay.
Now it's decreasing.
So now we measure FFR during continuous intravenous infusion of adenosine, 140 microgram per kilogram per minute. Patient, of course, feels some chest discomfort, and as you see, the FFR value is 0.56, 58, 55, so it's really very significant. According to outcome of the patient, this is very good indication for revascularization. And again, Professor Jan is pulling back the catheter, and again there is no such gradient across the mid part of LAD, and the most significant gradient is across the proximal LAD. So it is quite similar. Maybe now we have some drift. But we don't need to repeat it because it was painful for the patient. I believe that this is for sure significant disease there. We will of course recalibrate, we will do another equalization before next measurements, but I believe that we can trust this assessment. We have very long diffuse disease, but most significant one, according to physiology, seems to be in the proximal part.
And so also, before maybe some movement of the guiding catheter.
Yeah, maybe it was caused by guide. Yeah, you are right. So our decision was also to do intravascular imaging in this case, because this is young patient, long diffuse disease. We would like to treat it as good as possible, according to achieve the good long-term outcome.
What is your point about ECG? Sorry, I didn't hear.
To see on the monitor the ECG on the top. See the pressure, we see the gradient, but we don't see the ECG.
Well, yeah, it's too late. It's been recorded 2 weeks ago. We should have asked it to. What was the ECG 2 weeks ago, Dr. Chang? Was there any problem there? No, during adenosine infusion, was there any AV block or something?
No AV block, just comfort.
I believe that it was caused by adenosine infusion, which is very often.
Correct.
It should be included on the top.
Yeah.
Yep.
Take note next time.
Yeah.
That's an important piece of information. I think the question now, what is important for us to understand, what is the additive value of a pressure microcatheter in a landscape of different tools, different techniques? What is the add-on that this device has, the specificity that other technologies do not have? Anyone wants to take this question in the panel? Carlos, perhaps?
So, I think that the ease of use in terms of the device itself is one of the main characteristics. And again, I have to highlight, Manuele, that you have seen like Jacek and Yin decided to do both, resting and hyperemic. I think it was educational, but at the same time, it's extremely easy to perform. You know, you just push and pull, and then if you want to put it down, so you do it again. So I think it's making our life very, very easy when it comes to analyze the distribution of disease in a vessel. So I think that that's the major advantage of this device.
Yeah, so we got a very interesting question to me from the audience. So as we say that it's so easy to go in and out that you may have the pullback. So sometimes also you have diffuse disease. So that means that the gradient is coming up very slowly. So what is your opinion about the treatment? So should be stented partially?
You know, this is an excellent question. But for this excellent question, we need some more information, and that's why I'm inviting Dr. Chun Chang to give us a lecture, if you go to the podium, on the latest trend on intravascular imaging. Perhaps with this piece of information, we can be better in addressing the question that is coming.
Okay, thank you. So, as we know that IVUS already have more and more evidence which support its use. Also prove its advantage over the angio guidance. For example, in the ultimate study, which is also conducted in China, included more than 1,000 patients from the real world, which shows, with IVUS guidance during the 3-year follow-up, we can reduce 38% of target vessel failure compared with angio guidance. So very, very strong information. And also just recently, in the IVUS ACS trial, also from Dr. Chen Shaoliang's group, they included 3,500 patients, which shows, during the 1-year follow-up, with IVUS guidance, PCI in ACS group, we can reduce the TVF rate about 45%. In the IVUS group, the 1-year TVF rate is only 4%, compared with 7.3 in the angio group. So with IVUS, which give us more information about the vessel anatomy, according to this study, we can see around 74 patients, will change our practice. For example, we tend to use a larger stent or balloon. We will go higher infiltration pressure in order to get a larger stent area, and maybe we have to use a longer stent to cover more severe plaque burden lesions. And also we can find there's an encryptic expansion, which we also need to cover this with high pressure inflation, or maybe we can use shockwave to deal with stent and expansion. And also we can find incomplete stent apposition, and also maybe due to the dissection at the stent edge, we have to implant additional stent. But why is in the real world the IVUS penetration rate is still quite low? I think one reason is the reimbursement. Another is is the system easy to use or not. So many centers, they don't use IVUS very frequently. Either the physicians, they are not familiar with the system, or maybe there's lack of technicians which can help the physician to analyze the image. So for the current IVUS systems, just like from today and yesterday's live demo case in the main arena, we can see the old system, IVUS systems, they are low resolution images, which will limit the information provided by the IVUS examination. The lesions are not so clear, and there will be some artifact interference. Also, patients sometimes, if the lesion is very tight, like this patient, the slow pullback will induce ischemia. Patient may have symptoms, or sometimes, may even develop hemodynamic instability. This will lead to poor patient intolerance. And also the workflow and the learning. The current systems, they have short pullback distance, long learning curves, and also especially the difficulties with data interaction. So this will also, impair the use of IVUS in our daily practice. So with this new HD-IVUS with a 6 megahertz high resolution images, we can very clearly see the plaque rupture here, And we can also very clearly see the side branch. The image is really, really very clear compared with older versions, such as 20 megahertz. We can get more information about the plaque and also about the vessel anatomy. With this new system, we have 4 pullback speed options. Like if you want to do clinical studies, maybe you have to pull back at a very low speed, like 0.5 milliliter per second. So FPS will be 30, and also we have very fastest pullback. It's 10 milliliter per second. But in order to keep the informations, we won't lose any important information. FPS will be increased to 100. So this gives us more options depending on the patient situation. With the fastest speed pullback, we can shorten the time of pullback, and also we can improve our operation efficacy. We can see even with the 10 milliliter fastest pullback, we still have less artifact interference. We have more stable display even with this 10 millimeter per second pullback. The image is also comparable with this low pullback. So this is very important. We don't want to sacrifice the lesion informations with high-speed pullback. And this new system, we also have a very long pullback distance, 150 milliliter. Almost we can finish one pullback, even from the distal RCA to the proximal one. Just one pullback is enough. We will have whole artery images just in one pullback. And I think the most importantly, if we want to increase the usage of IVUS, it's just the image analysis platform is very important. With so-called in smart vision, we have intelligent full sequence lesion analysis with AI technique. We have auxiliary markers which can automatically tell you where is the MLA, and also the room area of the vessels, and also can highlight in the plaque burden area in longitudinal view, very easy to use. And we have auto segmentation, which will automatically identify and calculate the room area and also plaque burden. So this is very important for centers if they are not, if they don't have like very experienced technicians to analyze IVUS image. This platform will give us more convenience in analyze image and also guide our interventions. So this example just shows us, the system. So the analyze will be calculated very fast, and also tell you which is the whole pullback length, and we'll have the automatic analysis of all the lesions along the vessel. So it's very easy to use. And also very importantly, we have the image co-registration systems, which will co-register in real time between the IVUS image and angiography. This will tell you where to put our stent, and we have detailed view of the lesion and its exact location. So it's very friendly for the beginners. So with this new generation of HD-IVUS, we have clearer than before and faster than ever image. We have very good image quality. We have clear lesion details. We have less image vibration and interference. And with the fast pullback, patient can experience less chest tightness, palpitation, or other symptoms. And especially with this intelligent image recognition and measurement, with this EasyGo IVUS angio co-registration system, this is a very user-friendly workflow and shorten the learning curve, especially also very good for the beginners. Thank you.
Yes, you are in. So for today, we will use a high definition 60 megahertz True Vision catheter from Inside LifeTech company.
So I think the preparation of the catheter is very easy. Some catheters is very difficult to clear the air bubbles in the catheter. But with this one, it's very easy. Just one flush will clear all the air.
The special feature of this device is the long pullback, 15 centimeter pullback. So you can, with one pullback, you can assess all along the vessel, and there are 4 speeds of the pullback available: 0.5, 1, 5, and 10 millimeter per second. So especially in very tight lesions, you can shorten the time of the evaluation. However, afterwards, when we want to have very detailed analysis, we usually go for 1 millimeter per second.
So our first round we will use 10, right? For this.
As a first, yeah, usually 10, because it is tight stenosis, and we can expect some ischemia during the evaluation. So, yeah. Yeah. We have some artifacts, but now we are in a distal LAD. You see the vessel here is okay, and it's like 2.5 vessel in diameter. And now we pull back, and you see immediately very diffuse disease there. But of course we need to carefully assess. Now we can withdraw the catheter from the artery, not to limit the flow too long. And now we can assess and measure. There are 2 additional features of this technology which are really good. First, we have online co-registration available, which takes like 1 minute to do it, which is not so bad. And at the same time we have automatic assessment, quantitative assessment of the vessel, which is coming with this device. So now we do co-registration, and this is very easy then to be really sure where we are. You see the blue marker on angiography, which tells us where we exactly are with our probe, and you see the very diffuse disease all along the vessel, up to the proximal part. And of course, we have tapered vessel because there are many branches, including 2 quite large diagonal branches. Distally, this vessel is like 2.5, and in the proximal part is close to 4, which is maybe 3.5 at least in the proximal reference segment. So first of all, probably it would be very difficult to treat it with only 1 very long stent. We need 2 stents, which is also better because we have 2 bifurcations. So first we can treat with long 2.5 stent across second diagonal, do the pot, and then use another overlapping stent in the proximal part. What do you think?
Yes. 测量一下第一个支架到那个远端那个对角是几毫米？来个2.5 20的预扩。So the distal landing zone to this one is length is 35.
Now we see some measurements, and we also measure the length, which is possible with this system using automated pullback. So definitely distally to the diagonal branch there is quite long segment. It's close to 4 centimeters, but all along the vessel it is much more, of course.
So before we see the conclusion of the case, there is one important question that we need to address from our colleagues. Diffuse disease, focal disease, sequential stenosis, and difference between physiologic assessment and intravascular imaging. That is why I was waiting to show imaging before addressing this question, because IVUS shows to you where disease starts, where disease ends, more or less, from normal to normal. Physiology tells you something similar, but it is different. It's a different concept. There might be a crosstalk between disease and lesions. Who wants to take this one?
I'll take this one, and I think the question of the colleague and the case in particular is quite useful to explain this concept. Is when we think about focal and diffuse disease, sometimes the anatomy in terms of plaque is different from the physiology. What matters for the restoration of the flow is the physiology. So basically, if you have a step up, you can fix it, period. Now, that doesn't tell you where you have to land. That's a different story. So this is the typical case of functional focal disease and anatomical diffuse disease. So there is anatomical disease that does not produce pressure losses. It's just the plaque. Now, this is a debate that we can discuss, I think, for many hours. What is the best strategy? Of course, you have to cover the big pressure loss. That's obvious. The next question is, where do we land? And if you look at the landing zones that Jacek and Jin have produced, it looks like the only healthy landing zone that I can see from here is very, very distal. So now the whole discussion about short stent, DCB, only DCB, or full meta-jacket LAD, that's a discussion I think you had in the cath lab when you saw this information. Jacek, I don't know what was in your mind when you saw the IVUS and the physiology together.
I believe that if you use both, such situation like here is not so frequent that you have discrepancy. So big discrepancy because we have seen no gradient across the distal and mid part of LAD, and both with non-hyperemic and hyperemic index. So we didn't expect so much of plaque burden there. And of course this is then difficult how to treat it, knowing or keeping in mind that your stent should be positioned in a relatively healthy part of the vessel. Because otherwise you increase the risk of dissection, and even if it doesn't happen, then the risk of late failure due to restenosis is of course significantly higher. So to get the optimal result of this procedure by the intravascular imaging assessment, we need to go much more longer stenting than according to physiology.
Hold on, because we discussed about what should be the ultimate endpoint of a PCI, whether physiological or imaging one. Let's move on.
So what would be your strategy now after pre-dilatation?
We are implant stent distal to the Y protect diagonal, and also use geoprone technique to protect this branch when we deliver the proximal stent.
So as you see, after pre-dilatation in the proximal part, the long stent was implanted.
The proximal part doesn't look so bad. We can of course check on IVUS. This is ostium of LAD.
Maybe IVUS again, okay. Here no symptom, I think should be fine. Hemodynamic is stable,
So we have flow.
So this time maybe we do a slow pullback.
Because we need to decide and appropriately measure the length of the stent for proximal LAD. So we will measure just from the proximal edge of the stent, which was already implanted distally, and then we will find appropriate landing zone in the proximal part, and with this high definition mechanical IVUS and automated pullback, we will measure the length of the stent. Definitely it has to be at least 3/0 stent, and then we need to do also POT. Proximal to the second diagonal branch after stent's implantation. Now, you see we are in a stent which is distally well expanded. Maybe we need some high pressure post-dilatations afterwards, and we see diagonal branch, and then the stent is of course undersized, so we need to do POT, but we can even try to do it with the balloon from the second stent, which would be 3/0 balloon. Yeah, and here we see the proximal segment of the vessel with positive remodeling. We have a lot of calcium there, but there are no circumferential calcifications, and we have some rupture here. So predilatation was probably a good one. And somewhere here we have a good landing zone, I believe. So this at the level of this small side branch. So we will measure the length we don't need to cover probably this very proximal part of LAD. There is also plaque there, which is protruding into left main, but without stenosis, so we don't want to touch this. So please do the measurement. First, the distal marker, just not with, on the stent, 1 millimeter inside the stent, because we need to have overlap.
28差不多是吧？3.0 28/30，近端是在间隔一远已经啊，看有一个很小的间隔。一远。
So, Emanuele, I'm talking with Jacek. I've been impressed by three things. First, the co-registration with IVUS, that is extremely useful, not only to understand the plaque location, but the position of the stent. And I don't think I have never seen this with IVUS in this way. Second, the fact, of course, is HD. The image quality is quite nice. And the fact that the contours are also fully automatic based on AI. So this is, next generation and making our life easier when we use IVUS in the lab.
And there are also additional features to check the result of the procedure. You can ask the system to show you all the segments of the vessel within the stent, which are with less than 5.5 millimeters square. So it's really
What about distal
straightforward
landing zone?
procedure
A little bit plaque. 好像是不是有一点点斑块啊？对，是有一点斑块。可能不够远一点。斑块负荷多少？你看一下。38。
So after this high pressure post-dilatations, Professor John decided to use IVUS to check the stent expansion. So you see how it easily crossed all the lesions and stents implanted in the proximal and mid part of LAD, and now we are distally just at the distal edge of the stent, so we can push it a little bit maybe forward. Okay. So the distal stent is well expanded.
So I think it can be nicely appreciated that you can do a quick run through and check if the stent expansion is wide, and you can easily and safely dilate, post-dilate with the high pressures without any fear and get a great result.
Asymptomatic diagonal was probably okay, and we have this tapering. With this post-dilatation, you achieved good tapering of the stents. Proximally, we see the lumen, which is at least more than 3.0, and the proximal edge, it's not so bad, maybe a little bit of under expansion, but we covered what we wanted to cover. So the length of the stent is appropriate. We didn't touch this plug which is in the ostium. So according to IVUS, it doesn't look so bad. However, you can measure with automated assessment what is the minimum in-stent area. So you should mark distal edge of the stent and then proximal edge of the stent, and let's try to calculate the lumen area inside, what is the minimum lumen area with automatic assessment, which is now performed, and we will check for minimum in-stent lumen area, which is 4.48, and we have some small zone of the lumen area which is below 5.5, but it's not too long, and it's in a small vessel because this is distal reference. So Professor Jan decided to check this result with physiology, which again with true physio is very easy because we use the same wires that we have. PDPA is 0.92,
But definitely we can change into CFR. What is the CFR value first? So measure non-hyperemic, which is quite okay. It's 0.9. So it means that we achieved a good result according to non-hyperemic parameter. However, we have very long segment of LAD which was stented. So I believe that we can repeat also FFR assessment with IV adenosine, and then we can check the pullback. So have we started adenosine? Yes. Infusion. So we have started infusion, and we calculate FFR value, which is 0.91, but it is not maximum hyperemia. This patient is symptomatic to adenosine, so he will tell us. Yeah, he will tell us, and we will know where we have the full hyperemia.
I think it's quite good. Almost stable.
85, which is again, we would love to achieve more than 0.86. Yeah. But 0.85 is not so bad. So now Professor Jan is doing pullback. Okay. And it looks like that we have not significant gradient across the stented segment. We have just some residual gradient across the ostial LAD, but it is quite diffuse. And of course, it is also important that we want to treat this. We need to go for left main stenting. In case of good luminara, not the very big plaque burden, and only small gradient there, and very good result according to physiology and intravascular imaging. I don't know what is your opinion, but maybe we can just finish this procedure. What do you think?
Yes, I will finish.
Okay, Professor John, we can assess this as a very good result by angiography, but what is even more important, in the beginning there were some discrepancies between physiology assessment with the pullback, because there was almost no gradient.
Okay, we are left with few minutes that we should use to address several points of discussion. I would give immediately the word to Salvatore.
Yes, so first we have an advice actually to Inside LifeTech. One colleague is suggesting to add the co-registration to the microcatheter, so that actually allows you where is located the drop. And the second question coming from our colleague Omar. So Omar is worried about the crossing profile of the catheter, saying that, of course, in small vessel with diffuse disease, so this profile may add some more stenosis, let's say, on the top of the stenosis, which is already there. So it is something that we should be worried about.
So pressure microcatheter in small vessels, is it an issue? Any comment on this?
So I think it's a low profile. I think should be okay, even for the distal vessels. Like what's shown in this vessel, distal AD, we still got quite accurate measurement.
Any additional point from you, Salvatore?
No, actually. So one other colleague is asking about resting index and FFR.
Yeah.
So which one, I mean, is the best one to use if both are comparable?
Well, use the one you are most familiar with, I would say. But let me take the opportunity to address another important point that we touched upon before, which is what should be our target for percutaneous coronary interventions. Are we aiming at having a perfect angiographic and IVUS result? Are we aiming at having a value of 1 of final FFR? What is the good advice here for our colleagues when we do such a complex procedure guided with 2 imaging modalities, physiology and IVUS? Who wants to comment on that? I think we need to leave the room here with clear ideas and guidance.
Okay, let me just address this as quickly and a very easy point to remember. So if you're using physiology to understand what you have done, and you measure post-PCI FFR, in the right coronary artery, in the circumflex, after a perfect stenting should be 1. In the LAD, it cannot be 1 because the patient is lying down the table, the LAD is going up, there are hydrostatic forces that mathematically it's impossible to have a 1. So the highest possible FFR in the LAD is 0.95, 0.96, depending on the morphology of your LAD. So that's a bit the message, Emanuele. In this particular case, it's extremely interesting, Jacek, because they have a focal pressure gradient to begin with. Then they have a borderline, I would say, a bit disappointing FFR. If you start with a focal disease and you don't have a perfect FFR, something happened. And they realize what happened. They have a translational pressure gradient to the ostium of the LAD. And now it's a clinical decision. You want to make it a left-main PCI, or you accept to leave the room with a suboptimal result. But that's a clinical judgment, but you know what is happening. So that's a bit kind of the thinking behind this particular case.
I believe it's very important point because if this gradient is within the stent, then we have easy solution just to use, a bigger balloon or higher pressure to optimize stenting. But then at the end, we have negative values for both FFR and CRR according to ischemia, and we have only ambiguous lesion in the ostium of LAD, which needs very complex procedure. Nonsense to do that. So I believe that there are very additive information which can come from both modalities.
Yeah, I mean, to guide your final result, I think FFR is more important because this tells you if there is still ischemia or not. And the IVUS, which is done very quickly with a fast pullback, it can tell you if your stent has to be optimized or not. But your final result for a long-term outcome, that's going to be the FFR.
That's a good point. But again, I want to challenge even more because we have to make it simple. This procedure was providing us as a bonus a wealth of information, a wealth of data, a wealth of metrics. In real life, I'm not sure we would do it in the same way. I think I would start with physiology, I would continue with physiology till the end, or I would start with IVUS and would continue with IVUS till the end. Let's have at least an algorithmic approach. It's quite trendy nowadays to speak about algorithmic approach that would simplify the life of our colleagues on what to choose. They go down with the guide wire, with the pressure microcatheter, they get the CRR that is already pathologic. Do they need to do hyperemia, yes or no? And if yes, why? If no, why? Next, they put a stent. Do they need to do IVUS, yes or no? Share your algorithm, your mental algorithm.
So in decision making, I think FFR is very helpful in this case. You need to do FFR, and especially in a young patient where you basically don't want to treat too much and you don't want to place too many stents. You want to make everything sure that you have to treat that. So I would do both hyperemic and non-hyperemic. Once you decide to treat this, you have a long LAD lesion which might contain the ostium of the LAD. I would think of using imaging on top. If it wouldn't be the ostia LAD or proximal LAD, what we see in the pullback, you might get away only with FFR. But if it's getting complex, we know that imaging is going to help you.
Very well said. I think we are heading towards the end of this session. What should we retain? Well, in my opinion, what is striking to me is the ease of our procedures, of our complex procedure, facilitated by excellent tools and techniques. That is the first message I retain. Starting from the physiology tool. I don't know how many times you went in and out with this pressure microcatheter, but I suspect there were many. This is an edited case. So the real recorded case showed many pressure assessment, and the quality of the pressure tracing was just excellent as it was in the very first pressure run. So this is the first message for me. Intravascular imaging, I was really astonished by the quality of this imaging. I was commenting before with Carlos, and also that microcatheter, that IVUS catheter, you really used it a lot because you did a lot of pullback in and out. So it can happen that you fracture, you king it. No way, the quality was good till the end. So this is, of course, something that we pretended from company. Now we have it. We have good tools, reliable tools that we can use from the beginning till the end of our procedure. We hope we provided you also with some practical guidance, a way through the jungle of physiology indexes, the jungle of intravascular imaging tools and techniques, in order to achieve the optimal result for that given patient. It does not exist the optimal result in the ideal terms. They accepted a final FFR of 0.9 with lots of good common sense behind and clinical judgment, knowing that this is a young patient, he might come back with progression of disease in other segments, he might come back with restenosis. We still see sometimes stent failure, but they did the best for that patient in that given moment of the natural history. With this, thank you very much, and let's keep continuing our EuroPCR journey. Thank you.